Good afternoon, everyone. This is Dr. Mark Rudolph, Sound's Chief Experience Officer. Thanks for joining us for this week's COVID-19 clinical webinar for all clinicians. We will have time for some Q&A at the end of the presentation, so please enter your questions into the chat box at the bottom of the webinar control panel. We will answer those at the end. We are also recording this webinar, and we'll send that link out to everybody after the call. Today, we've got Dr. John Birkmeyer, Sound's Chief Clinical Officer, who will make some comments and then introduce our presenters. John?
Thank you, Mark. Hi, everybody. This is John Birkmeyer. I'm the Chief Clinical Officer at Sound. Welcome to our weekly COVID-19 clinical webinar. We're now in our 6th, going on 7th week of the COVID epidemic, and I speak for probably everybody on the phone that this has been just a grueling time for everybody in the U.S., across the Sound organization, but probably no more so than for the clinicians on the phone that have had to deal with sort of a brand new, clinically challenging, and sometimes very anxiety-provoking issue in your hospitals. Some of the stories that have come in, particularly from regions and sites within the Sound organization that have been particularly hard hit, are not only heart-wrenching, but incredibly inspiring and heroic. And I just want to thank all of you, that have been on the front lines and helping us manage patients struggling with COVID-19 and their family, and make their lives better for everything that you do. Before introducing our panelists for the day, I wanted to share with you a couple of important data points, some direct and indirect consequences of COVID on the Sound organization. The first thing I'll tell you is a little piece of good news, and that is that, as you know, via Sound Connect and other sources, we track the total number of patients that get admitted to Sound hospitals in every one of our 3 service lines. And for the first time, we're seeing evidence that we're not only on the plateau, but we're beginning to get on the downside of it. So as recently as a week to 10 days ago, we were admitting between 200 and 220 patients with test positive COVID a day, probably another 400 to 500 a day categorized as suspected COVID. As of this morning, those numbers have, give or take, fallen about a third. So while we're hardly out of the woods from a number of perspectives, it's probably the most definitive signs that we're on the downslope of the curve that we've had since we started. We also track kind of the impact of COVID on our clinicians as well as other Sound colleagues. While we've now treated in excess of 12,000 patients with COVID, I take it as partially good news that to date we've had only 17 physicians and APPs that have documented COVID infection. So far, only 2 of those colleagues have been ill enough to be hospitalized. Both of those individuals are now out of the hospital and seem to be recovering. The final indirect data point that I'll share with you is that partly as a result of hospitals shutting down elective surgery, but probably even more importantly, because patients are avoiding emergency departments and hospitals in general, most of you have appreciated that your hospitals are less full than they traditionally are. Across Sound as a whole, our hospital admissions are down approximately 35%. In emergency medicine, those volumes are down probably closer to 45%. Just this week, however, we're seeing our first indications that those volumes have begun to come back up. we have our fingers crossed that, our period of normalizing will be brief. But between now and then, we'll be working with all of you to make sure that, we can meet the expectations of our hospital partners, but also make sure that we do our best to honor our obligations to our providers. So today, next slide, I have the pleasure of introducing our three panelists. Dr. Nate Ruch, he's our Chief Medical Officer for Sound EM, Greg Johnson, our CMO for Hospital Medicine, and Dr. Sergio Zanotti, CMO for Sound Critical Care. Thank you guys, and take it from here.
Thanks, John. So we'll begin with an update on the situation within Sound, and I'll expand a little bit on John's comments regarding the flattening of the curve that we've seen in some areas. We can go ahead and go to the next slide. So this is a map from Sound Connect, which, each multicolored dot on the map is the location and magnitude of COVID admissions. And this graphic includes data for hospital medicine and critical care, but not emergency medicine. You can go ahead to the next slide. And, you notice here that there's a broad geographic distribution of cases, and, really no area where Sound partners is left unaffected. So the yellow line on this graph is the active admitted patients. And you can see we're still seeing, upward movement in that total number. And the blue on the bottom is new admissions. And, this includes both categories of patients. You can go ahead and go to the next slide. And this is age cohort data. And I think that there's really not too much surprising here. If you look at among suspected and confirmed patients, I would draw your attention toward the orange and the blue bars at the top, and you'll notice as you move rightward to the mortality graphic that those two expand fairly tremendously, which is expected from what we know about the disease. And you'll notice that the youngest age cohort, that those bars collapse as you move over to the mortality column. So, really the internal Sound data is very consistent with what we know about the epidemiology of COVID-19. And now I'm going to hand off to Greg Johnson, and he'll take us away with some discussion on post-acute management.
Thanks, Nate. I appreciate that. Again, it's Greg Johnson, Chief Medical Officer for Sound Hospital Medicine. And our focus on the last webinar was really about the beginning of the acute care episode with examining patients that enter our emergency departments, how we manage and really focus and triage those patients, transitioning into care plans that were discussed in terms of management of patients, looking at oxygenation, appropriate therapies, although primarily focusing on what supportive therapy is for COVID-19 patients, and then a brief mention of what we're doing with respect to getting those patients discharged. This is really a continuation of that prior webinar and the information in terms of understanding that as Sound, we're really focused on the entire acute care episode, which certainly encompasses long-term care facilities and most closely for us, skilled nursing facilities. And so what we are going to do is rehash a little bit about what we want to do for discharge planning for our COVID-19 patients in the acute care space, and then move into the acute care episode, which is now focusing on what do we do for long-term care facilities and how do we manage patients. And the management isn't necessarily as much about therapeutics as it is about how do we organize our thoughts and how do we best support our high-quality network partners and people that aren't necessarily part of our high-quality networks, but facilities that we need to be able to accept COVID patients as well as non-COVID patients. But how do we also make sure that we're managing them effectively so that way we're continuing to do what we've always done at Sound, which is manage the acute care episode exceptionally well. So Starting with discharge planning, I want to rehash a couple of particular items. First and foremost, a reminder that we're asking all of you to first and foremost focus on discharging patients when clinically indicated. We've received a number of questions and comments about when is it clinically appropriate, and both our recommendation that's consistent with the CDC states very clearly that when you think the patient's ready to go home, you need to get them set up to go home. Patients don't require meeting removal of any transmission-based protocols, and we'll get into the details of what those specific precautions are, and then what are the strategies to be able to do this. And we're going to talk more about the test-based strategy because of its application to long-term care facilities, but understand that first, for the majority of our patients, the non-test-based strategy, patients can have their precautions discontinued 72 hours after resolution of their symptoms, or within 7 days of when they began their symptoms. And so making sure taking an accurate history and basing discontinuation of those protocols is next. The test-based strategy, which does have limitations, not only due to the false negative rates associated with the test itself, exists, but we want to make sure that for long-term care facilities, we're typically recommending that to confirm that the precautions can be discontinued, it's 2 swabs that are 24 hours apart. Understanding that some of those are going to be limited because of the time, turnaround time for those tests, but understand that making sure that you get them done and providing that feedback to our skilled nursing facilities and long-term care facilities is critical. The other piece I want to touch on before we move specifically into the long-term care space is with the discharge to home. And when we publish these slides, the hyperlinks that exist and highlighted in yellow are there for you to link to the CDC recommendations about what specifically should be done in additional details. But for us, as we are discharging patients, want to make sure that, again, we've confirmed contact info and social supports. This is adapted from what is noted in the state of Washington, and a number of other states have mimicked it. We want to make sure that patients have 14 days supply of food and medications to ensure that they can maintain their isolation based on how you make those recommendations, but also that they don't have to come back out and the patients feel secure in knowing that they have what they need to get through whatever isolation they're put on. Reiterating the isolation that was stated before, and again, discharge at home doesn't require additional testing. A lot of people have asked that question, and unless it's required for another reason, it's not necessary. Also want to emphasize some other areas. First of all, that the Centers for Medicare and Medicaid Services, CMS, has waived the home health requirement in terms of whether or not a patient has to be defined as homebound. So if you want to send patients home with oxygen, you want to send patients home with a follow-up, home health follow-up, you can do that. CMS has made that waiver, and this is part of why what we've always done in Sound is to identify high-quality networks and those who are partners with us in helping to care for these patients. So identifying within our particular facilities if our home health partners have telehome health in order to, again, mitigate the number of people coming in and out, mitigating the spread, and also making sure that our patients are being cared for. Nate is going to talk a little bit more about the waiver for skilled nursing facilities, but that allows us to transition into the specifics of what we're asking to occur in long-term care facilities. And as I get into this, I really want to thank our Great Lakes, I think very specifically our Ohio long-term care, our SNPs program, that really helped to aggregate a lot of this information and make sure that we're helping to codify how we want to care for patients in the long-term care space. This is a rehash of a lot of the information that was about Wuhan that we've made sure to provide, again, consistent with the data that we've seen with respect to the age distribution, but understanding that these are the same symptoms that we're caring for, but the important part in the long-term care space is making sure that this is part of the differential early, especially when there are potential exposures, and reminding yourselves that it's in 2 to 14 days after exposure in the same symptom that we've been reiterating for the last several weeks. The key aspect here is to make sure that as part of your evaluation, there's some consideration of whether or not there are employees that have brought in potential infection, and more likely visitors before most facilities have shut down visitors coming in. But this helps to make sure that you're thinking about the COVID appropriately in the long-term care patient. For suspected and confirmed patients in the long-term care space, the first opportunity is to isolate the patient. I know that this is challenging given the limitations in terms of space in a number of these facilities, and I know it can be challenging because in many instances you're asking individuals to move. But most of the facilities and the CDC recommendations for facilities that are able to do this, whether it's creating a separate floor or a separate wing, is to isolate those patients. And then getting back to what we've been emphasizing and the CDC and WHO have been emphasizing for a long time, which is that we want to have source control, and specifically meaning that suspected and confirmed patients are wearing a face mask of some kind. The next step outside of isolation is making sure that if it's undiagnosed and it's still suspected, that all standard droplet precautions are being used. Again, we know that the ideal is to have appropriate amounts of PPE and the appropriate PPE for these particular conditions. I think we've stated it a number of times, which is, again, if we can get source control for the patients, and if we can make sure that there's at minimum a surgical mask available for our staff, as well as gloves and gowns if they're available, to make sure that they're being utilized, unless there is some high risk for aerosolization procedure that's going on. Those typically don't occur within our long-term care or skilled nursing facilities. The second component with respect to addressing these patients is to make sure that you're contacting the Department of Health. And this is mostly about testing than it is about anything else. Some of our post-acute partners have access to testing and have their own criteria for this. I think that it's critical that we're making sure that as part of the communities that we're serving, that we're notifying the departments of health to make sure that testing is available, and it can be potentially more widespread, considering some of the case reports that have come from a number of facilities, and we'll get into those a little bit later in the presentation. Want to spend some time on this slide because I want to reiterate, not just for our hospital medicine colleagues to understand what's going on, and not just for our SNFIS programs, but to underscore, as we are partnering with different skilled nurse long-term care facilities in the community, it's part of our leadership in these areas to make sure to convey this simple message. Stable patients can be cared for in these facilities if we do handle things appropriately. It's about hand hygiene. Again, these are the basics that we want to underscore, but hand hygiene, both before and after contact, and making sure that that's done in particular after removing PPE. If available, alcohol-based hand sanitizer in every resident's room. Tissues available because, again, if the patients want to clear secretions and make sure that this is done, that they can wash their hands, but make sure that they just are adequately comfortable. Very difficult to implement, but I think absolutely critical in terms of mitigating that community spread and making sure that patients are adequately cared for, is to help create pods of dedicated employees to care for those patients and make sure that we can teach effectively infection control for those individuals who are caring for those patients. It's no different than when we talk about cohorting patients in a hospital, but making sure that if we have dedicated employees, they're a lot more focused, a lot more practiced, and a lot more consistent with respect to their hand hygiene and utilization of PPE. Obviously, we're posting signs. The PPE that is available should be available immediately outside of affected residents' rooms. And then obviously you want to make sure that they have the ability to dispense of that PPE once they exit. And you have to make it easy for them, and that's part of the practice. But I want to underscore that stable patients don't have to go to the emergency department. We continue to receive some questions about whether or not all patients with concern over whether or not since testing is sometimes inconsistent, whether or not they need to go and get it tested. And because I'm emphasizing this about not stable patients not going to the emergency department, I'll ask my ER colleague, Nate Ruch, to chime in on some of the other patients.
Thanks, Greg. And I think that message about appropriate ED utilization is really important as we try and work together as a unified care delivery system, because we need to preserve both inpatient and emergency department capacity for patients who truly need it. And, stable patients who can be managed in place, really should be managed in place. So, assuming that decision is made, what are best practices for suspected or confirmed cases? And, expanding a little bit on what Greg spoke about, appropriate PPE utilization, including, respiratory protection, which focuses, on droplet. The other best practices, really you want to eliminate the number of patient interactions, and you want to try and minimize the number of staff that you have interfacing with patients. You want to use disposable equipment where you can. And, hand hygiene is really the foundation of infection control. And, obviously patients who are cohorted together, that's one way to contain it. But if you have staff that aren't utilizing hand hygiene, whether that's alcohol-based hand sanitizer or, really thoughtful hand washing, you're really putting folks at risk. You can go ahead to the next slide. So if you're observing a patient in place and they deteriorate, they become unstable, what are next steps that make sense? Contacting local EMS. And when that contact is made, it's critically important that EMS knows what to expect when they arrive, so that they can prepare and protect themselves and be ready to prepare the patient for transport. And, one of the things that we've talked a lot about in this venue in previous weeks is the importance of source control. And when a patient's being moved out of their existing room in the skilled nursing facility, it's critically important that not only the caregivers wear masks, but also the patient, because that source control, as in the form of a surgical mask, really helps mitigate risk to not just the ambulance crew, but the other facilities. And there's, I think it's also a good idea not to have folks enter the room where an unstable patient leaves immediately afterward. And if they do so, make sure they use respiratory protection. So obviously, as we've, the whole point of what we're talking about here is that skilled nursing facilities represent high concentrations of patients with comorbid disease, who are elderly, who are at substantial risk. So there's some, really high quality guidelines from the CDC and, the long-term care, acute rehab, and other skilled and unskilled venues. Their professional societies also have pretty good guidelines. And, we'll link to those in some of the notes from this presentation. But another best practice, if you're able to, is to cohort patients, essentially all new admissions, with the idea being that you can surveil them for concerning symptoms. And, we've, I think, talked quite a bit about the test characteristics of the available reverse transcriptase test, the PCR test that's most commonly used, the swab. And until antibody testing becomes readily available and widespread, that's going to be the way that we're screening folks. And I think most patients that are being admitted from the hospital at this point are likely being screened, but we all know that a single negative test doesn't have enough power to completely rule out disease depending on the prevalence in your community. So you can go ahead and advance, Greg. So how do we reduce risk? Really this, the foundation is hand hygiene and appropriate PPE use. And then the next layer above that is appropriate cohorting of patients who are both new to the facility and have concerning symptoms. Single rooms when appropriate, close surveillance for fever and respiratory symptoms so that you can be sure people are cohorted with the right group, and limiting contact. This is a very difficult thing to do in these environments because, these residents are often lonely to begin with. They have loved ones or family members who are really worried about them. But to keep facilities safe, it's very important to limit visitation, but to also limit staff contact with residents and to limit gathering for meals or, other times when transmission of infection can occur.
So picking back up from that, there are a couple of updates that CMS published as of earlier in the month with respect to long-term care facilities. And a couple of items that want to make sure that you're aware of and really help to evaluate, the appropriate patients to be transitioned. Are first, that temperature screening is for anybody that enters the facility, unless it's obviously the EMS personnel that Nate mentioned for those unstable patients that require transfer. They're asking that all patients are assessed on a daily basis, typically meaning that they're at least getting temperature screens, and that should be confirmed for the facilities either that you're working in or that we are affiliated with. And then the CDC and CMS specifically is noting that if testing is available, they're really asking that all residents be tested. It's a CMS document that is out and we'll make available after the webinar, but this is to reinforce that there really is a goal in getting more widespread testing, particularly to identify what could potentially happen with these patients. I did want to spend a little bit of time here in terms of reiterating what happens when we want to get patients back, because the number one frustration, or not the number one frustration, but I think among a number of frustrations of our hospital medicine colleagues is really getting patients back into the facility. And for our long-term care, our SNFs programs, I think it's a challenge in terms of working with the facility to understand which patients can be accepted. And I think based on this, which we've shared in briefly in this and the prior HM webinar, it's really about the American Healthcare Association, which is the Skilled Nursing Facility National Association. They've really provided some guidelines about what to do for suspected or active COVID patients. And the first thing is that there actually is ability to get these patients admitted to the facilities. I know a number of facilities have said, no, we're not taking these patients. But if you go to the link that is here and will be available in the slides afterwards, this grid really helps to provide some guidance as to how to get those patients within. And again, it's based on whether or not there is significant prevalence within the community area, and then based somewhat on testing. Patients, first off, our non-COVID patients can get admitted. I think it's important for everybody and us as leaders in our connection with not only high quality networks, but just our partnerships in the community to underscore we need to make sure that patients are getting care at the right level at the right time, and underscoring that our non-COVID patients can be admitted, and our recommendation that if the facility has had exposure to COVID, that the preference is that our non-COVID discharge patients that go to skilled nursing facilities are cohorted as well. They may not have that available, but I do think providing that guidance is pretty critical in terms of making sure that it's clear that we're trying to minimize transmission, but also trying to effectively manage the patient's stay and the patient's overall illness with respect to location of care. For asymptomatic cases or status is unknown, again, identifying what you have in the community on whether or not they have cohorted units, because if they do, they can accept the patients. And there is distinct clarity with respect to how to be able to do that, and the grid helps to provide some guidance. And then for positive patients, this reiterates that in most instances, they're going to expect the 2 negative tests within 24 hours. And so that should help to guide you in terms of knowing that if, as your patient is recovering, that you want to get testing to be able to facilitate that potential discharge. I want to touch on how we've been involved in Sound's experience across the country in managing an outbreak. I think most people are aware of the situation that occurred in Kirkland, where there was one healthcare worker that came in on March the 1st. Within 6 days, there were 7 patients that were infected. Eventually, of the 130 beds, within about 2 weeks, there were 80 plus admissions to the hospital, 80 plus infected people, a little over 50 that were admitted to the hospital, and 23 deaths. And so obviously, considering a lot of what we mentioned before in terms of isolation, hand hygiene, appropriate use of PPE, and cohorting are all pretty critical in terms of lessons learned in a very unfortunate situation. Nicole Schneider, our regional chief medical officer from Evergreen, shared with us lessons that were learned from another healthcare center where we have a partnership, in which case there was an outbreak. And what was shared was that because there was coordination between the post-acute and acute care teams in terms of setting expectations, A, our acute care team was able to be prepared. B, it allowed the hospital to make sure that there was a deployment of palliative care individuals to the facility to actually have advanced care planning discussions with a number of those patients that actually helped to make, first and foremost, do what we always do, which is take into account the patient's wishes and care for them in the environment that they wish to be cared for. And so knowing that we're going to discuss advanced care planning, and it's so critical in terms of how we as Sound have defined how we want to care for patients in the acute care episode, I'm going to turn it over to Sergio to discuss it in more detail.
Thanks, Greg. And again, thank you to all who are listening for all you're doing on the front lines. Today, I wanted to talk a little bit more about advanced care planning, but also other issues related to our interactions and communication with our patients and with their families in terms of making decisions that are aligned with their goals of care and with the prognosis, especially for those patients who have COVID-19. Can we go to the next slide, please? So we talked about this last week when we were talking about the top 5 areas that we should be focusing on. And one of them that I think has become very clear, and that was not something that we were talking about early on because we had not recognized, was the challenges that the pandemic has imposed on clinicians, on patients, and on families in terms of establishing not only goals of care, but also in terms of communication of what is going on with the patient and what would be the best decisions in terms of aligning the care we're providing with their prognosis, but also with what the patients would want. And I think that what we have found is that with most hospitals now dealing with COVID patients, restrictions to visitors are very common. Most hospitals are not accepting any visitors. Some have some exceptions. But what we have found throughout the country, but also throughout many of our Sound teams, is that these conversations of goals of care and trying to figure out what to do next or what would be best aligned with the patient's wishes is becoming very, very difficult because of the inability to talk with critically ill patients who have COVID, or the inability to really connect with family members and to communicate in an effective way. So along those lines, we talked about 3 big buckets. Number 1 was early goals of care discussions, which really is about acute care planning. And I think that advanced care planning, I think that a lot of that is very difficult when these patients are basically dropped off in an ED. They're very short of breath. Some of these are critically ill, especially the elderly patients. Physicians and APPs are overwhelmed with the amount of patients that they're seeing. Communicating with the family becomes very difficult. And just the sheer volume of what we're seeing in some of our programs makes it almost impossible for clinicians to have these extensive conversations at all times with family members. But I do believe that finding processes or figuring out best ways or best practices to have these early goals of care discussions, advanced care planning as soon as we can before patients decompensate is going to be very important. As we have increased number of patients, I think that establishing processes for family communication is going to be also very important. In many of our hospitals in New York, the sheer number of patients that they saw really was something that they never imagined they would be able to even care for. And speaking with our teams at NIAC, I know they very early recognized when their capacity was 5x of what they usually have with half of the team, that they were really in a very precarious position to really have these discussions at a good level, and figuring out ways of having a process where maybe there's a designated person who's calling families as soon as patients come to the ED. A lot of these things can be established in the ED because that's the first point of contact, and if that's when the family is available by phone. But really being very aggressive in identifying what patients would want and planning on appropriate goals of care, and establishing and communicating that so the team knows which patients would be taken to the ICU and aggressively treated with invasive ventilation, and which patients would not want that early on. I also think that another situation that we have seen over and over again, and we hear in the press, but we also may have had teams who have lived this, and I speaking with friends who have gone through this with their family members, is the recognition that a lot of these COVID-19 patients, especially our elderly patients, but also the younger ones who get severely ill, are dying by themselves in the hospital. And we talked about this last week, how in some of our teams, they have really made an effort to make sure that patients don't die by themselves, connecting patients who are very ill with their loved ones via FaceTime or other video conferencing, and really making an effort to, within all this isolation and social distancing, bringing families together in these very, very difficult and critical moments of people's life. So I just wanted to remind everybody about this reality that I think is something that we have to really put our efforts in trying to do the best we can. I don't think that there's a solution for all of this because of what we're living, but I do believe that focusing on this aspect is probably much more fruitful for patients and their families than going crazy and giving whatever the latest social media recommendation is, and really distracting ourselves from what it really means to be a compassionate practitioner. To that effect, I also wanted to introduce in the next slide some materials that will be shared with everybody via an email from Mark tomorrow. If you can move to the next slide, where we're going to have some educational material that we have shared with you before, but I think is even more timely today on the appropriate advanced care planning, and on really building a house with strong roots so that we can really do this in an organized way. I think that, again, a lot of what's important about these goals of care discussion is about listening and asking, as opposed to telling patients or family members what we think they should do. And in that, along those lines, building on first on asking permission to talk about this, building a relationship, understanding the patient story. This is not a COVID-19 patient. This is somebody's mother, somebody's father. They have a story. There's things that are important about their medical condition, but there's also things about their life and values that I think, even in a pandemic, we should seek to understand. Making sure that we ask permission to talk about the medical story and understand what they understand about what's going on, aligning our interventions with delivering, what we're doing, and really acknowledging how hard this is for everybody, not just being sick and being fearful of death, but being unable to be surrounded by our families when this is happening. I think has really presented a unique situation that I can't recall in my practice anything similar. And finally, finishing the house with a medical recommendation and summarizing what are the priorities for the patient and what we're recommending, and closing that with a collaborative decision making that hopefully lays the the days ahead of what will be done and what will not be done, so that everybody has a lot of clarity. In addition to the advanced care planning educational material that Mark will be sending, he has included, in the next slide, please, some COVID-specific scripts that I think are really, really valuable and very well done. And I think that I just have a couple of here, but the idea really is that you have, again, a way of establishing a relationship and asking the patient's story. So building upon that house that we reviewed, but with COVID-specific context. And then based on what you're trying to figure out, you might choose one of 4 scenarios of really, moving forward in terms of escalation of care, limiting care, withdrawal of care. But I think that I would encourage every clinician to read these materials, because I think that even if you think you're a seasoned communicator, having a systematic approach will make you better. And having scripts that I think are very useful and very specific to COVID, and understanding that you're going to be doing this over the phone is also, I think, very, very powerful and useful. And finally, I think these scripts can be very helpful also in facilitating communication with the families by other team members when the clinician is unable to do it himself. So we really just wanted to use the webcast, the webinar, to reinforce what we believe is an important aspect of caring for patients in COVID-19, which is really aligning our care with their goals of care, understanding what patients are going through in their families, and really making a deliberate effort to provide compassion in such a difficult time. And we wanted to also encourage everybody to look for their email for the email from Mark tomorrow, and really go through that material. I think it's very, very useful, has a lot of tips that no matter where you are in your clinical practice will be very, very helpful during these times. So I'll stop there, and I think Mark is going to add any comments, and then I think we're going to Q&A.
Thank you, Sergio. I will just add to Sergio's fantastic quick overview there that the materials that we're going to be sending around are geared towards the situations that all of you are facing in terms of not having a lot of time and having people that are acutely ill and, possibly at end of life. So, I encourage you to set aside the idea that we're only focused here on some sit down for 45 minutes with a family. That's not the only situation we're talking about. We're talking about using tools that can help you to even have a 5-minute conversation when you need to have that kind of quick and efficient conversation. So I think that there's something that pretty much everybody will be able to take away, as Sergio mentioned. And one of the components of the resources we'll send is it's going to be a 5 to 7 minute video presentation that will, from beginning to end, help you address a goals of care discussion effectively. So it won't take a lot of your time. Okay, we have a handful of questions that we can get started on. So the first question is that you mentioned at the beginning of the presentation, quote, discharge when clinically indicated was mentioned. That is vague and different for different diseases because we know what their course usually is. Fevers 18 hours ago, still short of breath but on room air, heart rate 110, etc. I recognize there isn't good data now, but this has been very challenging in terms of what does discharge when clinically indicated mean?
It's an excellent question, and I think obviously that's going to be dependent on the patient that you have in front of you. I think that some of the basics that we're looking for are certainly a patient being afebrile, a patient that is certainly less dyspneic than they were when on presentation, looking for improvements in their overall oxygenation are likely key signs that we're looking for patients to be able to be discharged. I know that there are a number of patients that have been discharged on home oxygen, so that way they can be out of the hospital, back in their environment, but understanding that they're going to maintain specific precautions. But some of that's also going to be dependent on what we recognized as clinically stable from from the picture of the patient that's in front of you. And so I think looking for those key items that we would typically look for in terms of patients that are recovering from acute respiratory illness are similar. And understanding that the course of this, most of the patients that have been seen in terms of a number of the case studies continue to improve. The ones that are going to rapidly decline, I think, based on your training and based on the patient you have in front of you, will be pretty obvious, and you'll want to obviously continue to monitor them appropriately.
Okay, thanks. And Greg, so can I infer then from both the question and also your answer that we shouldn't necessarily be looking at the COVID patients differently than other patients with respiratory disease from a standpoint of discharging them?
I think that is consistent, yes.
Okay, a related question. I'm running into problems where patients' elderly spouse can't remain separate or doesn't have protection or lives with a roommate in a small space. Many of these discharges feel risky to family members who don't have a way to separate or protect themselves. Any guidance? It's a tough one.
That's obviously an incredibly tough situation when there are limitations, and I think understanding what is available and what can be done in order to mitigate potential spread is really what you're considering doing. So obviously, if they have a roommate, and the patient is stable to be home, I think you're thinking about things like, can a mask be provided? Can there be limitations in terms of additional contact? Is there adequate water in hand washing? I know that in some instances, even flow of water is critical. And is there going to be enough food? Is the patient going to have appropriate follow-up? So I don't pretend that there's an easy answer based on the information that's available. I think again, everything that we've emphasized is for you to do what you were trained to do, which is be an excellent clinician. Consider those factors that are in there and utilize the information that you have in front of you to make a decision that may be that the patient is discharged to an alternative location until you can make it, you feel it's more comfortable. But I think providing some guidance as to when that those transmission-based precautions are discontinued is also important.
Okay, thank you. Any further information about hydroxychloroquine that is available?
I'll take that one, Greg. So I think that the reality is that there still is no peer-reviewed, published clinical trial that supports its use. I think that we're seeing a lot of reports on the press. That is not really evidence. And we hear reports on both sides. There's people obviously who keep saying that it works, and people who now are reporting that trials, for example, in Brazil, have been stopped due to increased toxicity in patients with prolonged QT. I believe that we are really facing a very unique situation where lay people are pushing for drugs that have no evidence within a pandemic. It doesn't mean that I'm not saying that there's no potential that they couldn't work. There's just no proof that they do. To give people an example, a lot of what people are quoting for the combination of hydrochloroquine with azithromycin is based on 6 patients. So we're talking about millions of infected patients, and people are making decisions. States are making decisions on a study that included 6 patients within a group of 20-something patients that actually got both. So I think that we have to be very careful. There are trials ongoing. Hopefully we'll get some answers. But I think that unfortunately we put ourselves in a position where whatever the result is, there's going to be a lot of angst afterwards, because we have not taken a unified approach and really thought scientifically and really promote drugs that have proof or strong evidence that they work, which we don't have. So I think that there's no new evidence. There has never been any true evidence. it's all based, I think, on what's published in social media and in the press, and that in a situation like this is very unfortunate.
Yeah, I have two quick things to add, Mark. One would be there's a statistical point that's totally lost by the popular media here, which is that this condition has a very substantial rate of spontaneous improvement. So separating, treatment effect from spontaneous improvement, is challenging. And I think Sergio highlighted a key point, which is the combination of hydroxychloroquine and azithromycin has, additive cardiotoxicity. And, I think that, the best guidelines that I'm aware of were released recently by the Infectious Disease Society of America. And I would encourage everyone to check the IDSA website. And I think they have a thoughtful approach. And really the summary of what they say is that you're likely doing your patients a disservice if you're treating them outside of a clinical trial and without the advice of an infectious disease physician.
Okay, great. Thanks, guys. So we do not have any additional questions, but we've got some additional time. So if you want a question answered, I would say go for it. And okay, do have another question now. Using history as our guide, the 1918 flu pandemic came in 3 waves, with the fall wave being far deadlier than the previous spring. Do we think this model might be a possibility?
I think that what we think really, the people on this call is irrelevant because we have really no epidemiological experience and it's not our area of expertise. However, I do believe that that is the current debate. We are seeing that in some places the numbers look better than we thought they would, and a lot of people believe that that was due to social distancing. I think that the debate is if we reopen that distancing very quickly, there could be a second wave. And I think that the question is, what are the things that we need to have in place for that to happen for the reopening without that big wave? But I think that it's a great question. I don't think that anybody on the panel has the answer, but it is the current debate of what would be the risk of just saying, oh, we're over this, let's get back to normal very quickly without the right changes in place.
Thanks, Sergio. Anyone else want to chime in on that one?
Sure. I think that Sergio summed it up well, which is we don't really know. I think that the good news is that our healthcare system has learned a tremendous amount about what's required to navigate a pandemic. And, I think if anything, perhaps the greatest silver lining of this is that we'll be far better prepared if there is a cyclic nature to the infection.
Yeah. And Nate, just a quick shout out to you because you've been involved with Sound's efforts to obtain some PPE and distribute it, particularly to Sound sites that are struggling in that area. I wonder if you could give an update or just what is your impression of the PPE situation at Sound sites across the country?
We haven't seen any critical shortages where needed items were totally absent. We certainly have seen sites where N95 masks are being reused, and I think that's widespread. We're starting to see some tightening of supply around some items that we don't have in inventory, most notably gowns. We received a couple requests for gowns from facilities. The good news is that a number of weeks ago, some moves were made to really assist with the supply chain, and the supply chain, dynamics for all the needed PPE, are improving. And, I think really the biggest bright spot for me has been talking with our colleagues in New York, and we have 2 emergency departments with the Montefiore system, one of which is in New York City, and they've received PPE and really don't have any critical shortage. So that's been great to hear.
That's very encouraging. Thank you. I do have a really good question. When can a healthcare worker who had symptoms of coronavirus but no testing on account of testing not being available, when can that person return to work? So had symptoms of coronavirus but was not tested.
Yeah, so if you're looking at the
Go ahead,
CDC,
Nate.
yeah, sure. So the CDC guidelines would say that no fever for 3 days and 7 days since symptom onset. You know, their advice is divided into two pathways: testing based, which obviously doesn't apply in this case, and symptom based. And if you're afebrile, improving, and it's been 7 days since symptom onset, you can return to work. Which, you know, a kind of an aside to that is, think about how much shorter that timeline is than if you're in a market where testing is constrained, you know, and getting results takes quite a while. Yesterday, the CEO of VM, Dr. Mike Presley, and I recorded a podcast with a gentleman named Dr. Mark Plaster, who writes a column in a emergency medicine throwaway journal. And, you know, he works as a nocturnist and was tested. And the turnaround time for the test that he had done, which was a couple of weeks ago, was 19 days. And despite the fact that he had no symptoms, he was out of work the entire time.
So guys, we're 4 minutes from the top of the hour. Presently don't have any additional questions. Any final thoughts before we wrap up? Sergio, do you want to start?
Sure. I mean, just once again reiterate our appreciation and gratitude for everything that our clinicians are doing at the bedside. Some of the stories that we hear from our sites are really humbling, but also I think very empowering in terms of what people are capable of doing when things get really difficult. And again, I mean, I think we'll continue to communicate. Please send us questions. Tell us what you want to hear about. I think it's been, like John said, 7 unprecedented weeks. I still think that what lies ahead is still unprecedented, and hopefully we've avoided a catastrophe such as what happened in New York and in Italy and many of our cities and states and programs. But I do think that there's going to be no return to normal, just a new normal, and together we'll obviously be much better equipped to navigate that. So thank you again.
Thanks, Sergio. Greg?
I'll say the same, because we can't say thank you enough. Of continue to do the excellent work that you've been doing. What the feedback not only that we're seeing in terms of the number of videos that are coming out, as well as what we're hearing from a number of hospital partners in terms of sound clinicians stepping up and really helping to lead efforts continues to be remarkable. Reiterating that we want to hear from you, because we'll continue these as long as they are seen as valuable, that you're getting additional information, and our goal is to make sure that this is tailored for you, so that way you can put it into action at your sites and at the bedsides. But thanks again, and appreciate all of the questions as well as the discourse.
Thanks, Greg. Nate, any last comments?
Oh, I would echo what my peers in critical care and HM just said, which is thank you so much for all you're doing every day. I think there's never been a time where hospital medicine, emergency medicine, and critical care have been more important to our country. And it's really been very rewarding for me personally and professionally to work with all of you. So I would also say, you know, what Greg said really deserves underlining, which is that we're working very hard to create high quality content for you. So if there's something that we can talk about, if there's an expert we can bring in, if there's something we can do to help you that's, you know, information based or otherwise in your day-to-day work as we rise to meet the challenge presented by COVID-19, let us know. Use the email alias that's on the screen. Call any of us. We're here to support you.
Thank you, Nate. And I just want to add that, a lot of what is happening out there that you all are facing very bravely is pretty hard it's hard to see and hard to experience, and, in some ways invigorating to be a part of, but, when all the excitement dies down, it can feel pretty lonely. And if you're struggling in any way, we have a number of resources for you that we've been circulating almost weekly in some well-being communications. All of your chiefs and medical directors know exactly how to reach the peer support program, which is on the Knowledge Center. Just encourage you to reach out and take advantage of those resources if you feel like you could use a little help. So thank you again. Please continue to send your questions to the COVID email address that you see here, and keep up the good work, and we'll talk to you soon.